Good morning. It's a real pleasure to be here. It's always hard to follow Dr. Young. He's such an outstanding teacher, and I always learn new things from him. For example, I never knew that the thyroid gland felt like mashed potatoes. And so I am going to, on Monday when I do a thyroidectomy, recheck on that. But thank you, Bill. All right. So my job this morning is to talk about thyroid and parathyroid disorders in the MEN patient. And I was told by David not to be exclusive just about MEN1. So if there's time, I want to leave time for questions as well. If there's time, we'll talk a little bit about thyroid disorders and parathyroid disorders in the MEN2 patient. So I thought I would start with a real case. This is a patient who came to Mayo Clinic in 1998. She was a 43-year-old female at that time. She came with her daughter, who also had MEN1, and her father had died 12 years earlier from, quote, carcinoid, but we really couldn't obtain any more history than that. But he also had hyperparathyroidism, so pretty clear we're looking at an MEN1 family. She was noted to have elevated calcium levels in her blood at age 28. Nothing was done at that time. She went along, and 8 years later, they found that both her calcium and parathyroid hormone levels were elevated. And shortly after that, at home at her community hospital, based on an imaging study, she underwent removal of a single adenoma at age 41. And not surprisingly, she was not cured. And this is something that we see very frequently when doctors really don't have a lot of information or knowledge about MEN1, and they remove the biggest gland, and unfortunately most of these patients are not cured. This patient had a prolactinoma. As Dr. Young talked about, it was a small prolactinoma, and she was treated with Parladil, and that kept her prolactin under control indefinitely. Her daughter had a single parathyroid adenoma, again by the same surgeon, was removed in 1997. None of the other glands were touched, and she was not cured. So she comes to Mayo in 1998. She has what we call persistent hyperparathyroidism. Calcium and PTH levels are still elevated, but she also has recurrent epigastric, in other words, stomach pain, heartburn, reflux, inflammation of the stomach, and duodenum. And she doesn't have the usual cause of ulcer disease, namely due to a bacteria we call H. pylori. On examination, she appears well. She's overweight, no rashes. She does have a neck scar that's well healed. And these hormones that you see here in yellow are all elevated. Her prolactin, her glucagon, which is a pancreatic hormone. Human pancreatic polypeptide is another pancreatic hormone that we sometimes use as a marker when patients don't have tumors in the pancreas that actually produce specific hormones. Her gastrin levels elevated, so that's consistent with her history. She has Zollinger-Ellison syndrome, and she has persistent hyperparathyroidism. And we did a nuclear medicine scan on her, and by this point, it demonstrated that she had 3 other glands that were enlarged. Her CT scan of her abdomen was unremarkable, and it's not unusual because oftentimes these pancreatic, or especially the duodenal tumors, do not show up on CT scan because they're so small. She had a couple of small indeterminate nodules in her liver. It wasn't clear what these were. She had on what we call endoscopic ultrasound, and many of you may be familiar with that. On that study, which is very sensitive, we could see multiple pancreatic islet cell tumors, and these were primarily in the head of the gland. She also had a gastric nodule, and one of the tumors that's overrepresented in MEN1 are carcinoid tumors of the stomach, and she had inflammation of the duodenum. So in 1998, August, we did a subtotal parathyroidectomy where we went back in and removed 2.5 out of the 3 glands, leaving a small remnant behind. We also removed the upper part of the thymus gland because we know in MEN1 about 20% of patients with MEN1 will actually have a 5th gland in an unusual location, oftentimes being the thymus. And we took some of the tissue that we removed and we froze it in case we overcorrected the situation. We'd want that available to try to transplant back in the future. But this very nicely brought her calcium down to a level of 8.8, which is what we like to see. And then she did well from that. And so a few days later, we took her back to the operating room. We did an abdominal exploration. We opened her abdomen. Fortunately, the things in the liver turned out to be benign. She had an unusual neuroendocrine tumor in her bile duct, not in the liver, but in the bile duct. It's very unusual. We've had 2 patients with this over my career here. And there were multiple little islet cell tumors throughout the pancreas. And she had this carcinoid tumor in her stomach, so we resected, we removed the carcinoid tumor in the stomach. And because she had this malignant common bile duct tumor, and most of her disease in the head of the pancreas, we did what's called a Whipple procedure, where we removed the head of the pancreas and the duodenum. And there were a couple of additional tumors in the body and tail, which we enucleated. This is just a picture, an ultrasound picture. What you see here, this black area, this is outlining the common bile duct that brings bile from the liver to the duodenum. And in here, you can see this duodenal, what turned out to be a gastrin-producing carcinoid tumor. And I won't go over the pathology with you, but just to say she had an uneventful postoperative course. We were able to normalize her serum gastrin level. You can see here after the abdominal surgery, it's major surgery, her calcium level went down even more, and her phosphorus and her PTH level is a little bit on the low side as well. In follow-up, a couple of years later, her gastrin's still normal. Her calcium and PTH, parathyroid hormone level, are looking good. We don't find anything additional on imaging. She's overweight and does have some glucose intolerance, in part related to that, in part related to the operation we did on her pancreas. So just kind of give you a little overview of a rather typical patient that we might see in our practice here. And what I'm going to focus on in terms of MEN1 is primary hyperparathyroidism. And we know, as Dr. Young pointed out, there are less common disorders associated with MEN1, but they're overrepresented. They occur more commonly in MEN1 patients than they might be in other patients. And some of these less common manifestations include adrenal tumors, which we've talked about, carcinoid tumors, and the cutaneous and mucosal abnormalities, but also something that's rarely discussed are thyroid neoplasms, and we generally think of MEN2 and medullary thyroid cancer, but in MEN1 there is an overrepresentation of follicular thyroid tumors. So how do we approach these? We approach these exactly like we would in anybody that comes to us with a thyroid nodule. If we get an ultrasound or on palpation we feel something, we'll follow that up with an ultrasound exam. And under ultrasound guidance, we'll stick a needle in it to get cells for the cytopathologist to look at under the microscope. We also check the TSH level, thyroid stimulating hormone, which is a hormone that the value tells us how is the thyroid gland functioning. Is it overactive, underactive? And so we always want that information. And if it turns out that the cytology, in other words, when the pathologist looks at the individual cells, if it looks suspicious or clearly malignant, that patient will undergo a thyroidectomy, either half the gland or the entire gland, depending on whether it's benign or malignant. So that's all I'm going to say about thyroid disorders in MEN1 because they're pretty uncommon. We've already heard about the 3 Ps, and I'm going to focus now for the rest of my talk pretty much on primary hyperparathyroidism. And what you're seeing here, this is a neck incision. The neck has been opened up. This is the thyroid gland here, and I can assure you it doesn't look or feel anything like mashed potatoes, okay? More like a chicken liver, okay? But what you're seeing here is the inferior parathyroid gland, which looks very normal. It oftentimes has this little halo of fat around it, so you can appreciate how small it is. But here's a giant parathyroid adenoma that's arising from the superior parathyroid gland. And it's not unusual in MEN1 patients to see asymmetry. In other words, one gland may be very big and the others may be just slightly enlarged or totally normal in appearance. Okay, so we need to know that. We need to know that the patient has MEN1 syndrome, and then regardless of what the parathyroid glands look like, you need to take out several of the glands, at least doing a subtotal parathyroidectomy, or at least taking out 3 glands, and sometimes we take out 3.5. So primary hyperparathyroidism is most common in women over the age of 50. It affects both sexes, all ages, and races. And there are about 100,000 new cases annually, with 1 in 1,000 to 1 in 500 per year in the United States. So why does it happen? Why does the calcium level go up? We heard a little bit about this already, but these cells in the parathyroid glands, all 4 or 5 parathyroid glands, are abnormal, and they can secrete excess parathyroid hormone that's not under control of anything else in the body. Normally, when a person that does not have primary hyperparathyroidism, when they intake calcium, the calcium level goes up in the blood. What normally happens is the parathyroid glands decrease the amount of parathyroid hormone that they're releasing, and the calcium level will fall. And few patients with primary hyperparathyroidism remain symptomatic. I think that's an important feature. Now, in conventional sporadic primary hyperparathyroidism, 85% of the time we're dealing with a single tumor. In about 12 to 15%, it's multi-gland disease, and fortunately, in less than 1%, there can be a cancer. Now, in familial cases, like MEN1, it's most common in MEN1, and 95 to 100% of the patients will eventually, if they live long enough, will get primary hyperparathyroidism, and it's usually one of the first manifestations to show up in the second or third decade. In contrast, in MEN2A, only about up to a third of patients will develop primary hyperparathyroidism. There's also an entity called familial isolated hyperparathyroidism, where there's a family history of hyperparathyroidism, but they don't get any of the other manifestations of either MEN1 or MEN2. And then there's the very rare HPT, jaw tumor syndrome, and this is a rare familial disorder. The genetic mutation is known and can be measured. And these patients usually have just 1 gland involved, but they also have an increased risk over the normal population in developing a carcinoma. Now, less than 20% of patients with hyperparathyroidism, and this includes the MEN1 patients, have truly symptomatic hyperparathyroidism. And this includes symptomatic kidney stones, fractures, an entity that we call osteitis fibrosa cystica, which is very advanced bone demineralization and can lead to basically hollow spots in the bones. Patients can get what's called a hypercalcemic crisis. If their calcium level goes up too high too quickly, they can actually end up in a coma. And finally, pancreatitis is a rare manifestation of symptomatic hyperparathyroidism, but it can occur along with peptic ulcer disease. Other manifestations include loss of bone density, osteopenia being the early phase, osteoporosis being the later phase. You can have asymptomatic fractures of the vertebra on the spine. You can have excess secretion of calcium in the urine. You can have damage to the kidneys, and you can have kidney stones. Other manifestations include fatigue, muscle weakness, neuropsychiatric disturbances such as depression. You can have GI, gastrointestinal disturbances like pancreatitis and peptic ulcer disease. And it's also been shown that long-standing hyperparathyroidism is associated with impaired cardiovascular health and increased mortality. Now in MEN1, the multi-gland disease, in MEN1, this is, as I stated, is multi-gland disease no matter what they look like when you get in there. It's often asymmetric. Some glands are bigger than others. 20%, 1 in 5, will have a 5th gland, and oftentimes that's in an unusual location, different from what Dr. Young showed you with the standard anatomy, and that most often that will be in. The other thing that we know about primary hyperparathyroidism in MEN1 patients is that the manifestations that I outlined for you tend to be more severe as compared to patients that have sporadic or non-familial hyperparathyroidism. The diagnosis is relatively simple to make. The patients have an elevated calcium, they have an elevated or an inappropriate parathyroid hormone level. We measure their calcium clearance because there's a very rare entity where the patient looks like they have hyperparathyroidism biochemically, but the calcium levels in their urine are very low, and these patients don't need to have surgery. We typically will do, or I should say I do, not everybody agrees to this, I like to get nuclear medicine scan in the MEN1 patient, not to try to identify 4 abnormal glands, but to identify a potentially ectopic or 5th gland in an unusual location. Patients with MEN1 are not candidates for minimally invasive surgery. When we see a patient with primary hyperparathyroidism and no family history, what we do in those situations is we typically will go after the one gland that lights up on a scan, ultrasound, or a nuclear medicine scan, and then we take that out, we check the parathyroid hormone level, and if it drops down to normal, which most of the time it will, we're done. That's minimally invasive parathyroidectomy. Patients with MEN1 are not candidates for this. You need to find all the glands and do at least a subtotal parathyroidectomy. So what are the indications for surgical intervention? Because one thing that we know for sure is that whatever surgery we do for parathyroids and MEN1, it's palliative. We're not going to cure the patient unless we take out every last bit of parathyroid tissue, which leaves the patient with a disorder that's worse than the disease itself. So we operate on patients who are clearly symptomatic. They're passing kidney stones, they've got osteoporotic bone fractures, or they've had an episode of hypercalcemic crisis. If the calcium gets up over 1 milligram per deciliter above normal, so typically in the 11.1 range or above, that would be time to do the surgery. If they have calcium deposits throughout the kidney, that's called nephrocalcinosis. That would be an indication to intervene. Hypercalciuria means lots of calcium in the urine, and they had previously taken that out of the NIH guidelines, but now it's going to be back in the latest guidelines. Because if the urine calcium is very high, it tells you that the patient's at risk for kidney stones, and also that there's more bone turnover going on, and they may be at more risk for osteoporosis. If the kidney function is decreasing or the bone density is getting worse, those would also be indications to intervene. And finally, if a patient has Zollinger-Ellison syndrome due to a gastrinoma, we know that calcium will stimulate gastrin-producing cells in a tumor to produce more gastrin. And we can do the subtotal parathyroidectomy and oftentimes bring the gastrin level down, way down, so that we can heal up their ulcer disease before they potentially go to surgery. So the treatment involves identifying all the glands. We do a subtotal parathyroidectomy, 3 to 3.5 glands, with autotransplantation. I'll sometimes transplant tissue in the chest wall and wait till the next day to see if there's still measurable parathyroid hormone, and that will tell me that my remnant is working, and will take out that little transplant at the bedside. And we also do a transcervical thymectomy, meaning through the neck incision, we pull up what thymus gland we can to see if there's any abnormal tissue there. Another alternative is to take out all the glands and transplant some into the muscle of the forearm, but that's associated with a higher risk of permanent low calcium, which is not ideal. And again, we do a transcervical thymectomy, as I mentioned. Once I've done my subtotal parathyroidectomy, I like to check the PTH level in the operating room, and if it falls down into the normal range, I'm happy. The surgery, again, is palliative. You shouldn't expect a long-term cure with this. Some do. Recurrence rates are high because you're leaving behind abnormal tissue. Reoperations, when we do them, oftentimes focus on just a single gland that's been left behind. So we can either go back in surgically, or more recently, we've been treating these remnants that recur with ultrasound-guided ethanol injection to try to bring down the calcium and PTH, and that can be successful. And the last couple slides I have here on hyperparathyroidism is just to show you in MEN1 what the recurrence rates are. They're much higher than it would be with sporadic hyperparathyroidism, where we're dealing with just a single abnormal gland. Here you can see that the recurrence rates are anywhere from 20 to 60%, depending on which operation that you do. Persistent hyperparathyroidism, meaning hyperparathyroidism that is there right after the surgery or recurs within 6 months after the surgery, is relatively low. But these are the numbers here that concern us. What number of patients end up with a permanently low calcium level? And up to 30% of patients undergoing a total parathyroidectomy, they can have hypoparathyroidism. And that's why I favor, and most of my colleagues will favor, doing a subtotal parathyroidectomy. The risk in experienced hands of nerve injury is relatively low. Now, what can we expect from reoperations of parathyroid surgery? At best, about 2/3 will end up with normal calcium levels. 30 to 60% will get additional recurrences. 10 to 30% will end up with a low calcium, which can be really problematic. And 1 to 5% can end up with a nerve injury to the vocal cord that can lead to a persistent hoarseness. David, how are we doing on time? We're good. So I'll just mention, I've got a couple slides here on MEN2A. It's obviously a different syndrome, also autosomal dominant. 100%, just like 100% of people in MEN1 will develop hyperparathyroidism, 100% of people that live long enough with the MEN2A syndrome will develop a potentially lethal medullary thyroid cancer. And these can start to occur at a relatively young age, and depending on the genetics, will oftentimes recommend to the family that the thyroid gland be removed by age 4 or 5 before we have invasive medullary thyroid cancers. Now, the hyperparathyroidism is different in MEN2A patients in that it only tends to involve 1 or 2 of the glands, okay? And the symptoms and the sequelae from the hyperparathyroidism does not seem to be as severe as it is with the MEN1 patients. So in this case, we only remove the enlarged glands. We don't do a subtotal parathyroidectomy. We try to preserve the others. And we also have to remember that the second most common manifestation in MEN2A are these adrenaline-secreting pheochromocytomas, and they always take precedence in terms of management over the other manifestations of the MEN2A syndrome, and I'm sure we'll hear more about that. Now, MEN2B is a very aggressive disorder. Fortunately, it's very rare. About 85% of the children will develop medullary thyroid cancer, and oftentimes this can occur in the first year of life. So if detected, we operate on these patients during the first year of life, preferably by 6 months. And another important thing is that unlike MEN1, most of the parents in MEN2B do not have the mutation. So they look entirely normal, and the children have a de novo or a new mutation. There's no parathyroid disease in MEN2B. They have a very classic appearance. They look tall, what we call marfanoid in appearance, long, lanky extremities, a high arched palate in the mouth, and oftentimes they'll have thick lips and a lumpy, bumpy tongue, and about half these children will get parathyroid disease. 100% will get medullary thyroid cancer. This is the thick lips and lumpy, bumpy tumors that you can see on the tongue. These are neuromas, and it's very characteristic. Now, what happens, we try to get these kids into surgery before they develop invasive cancers, but what happens once there's established disease? In those situations, we take out the entire thyroid gland. We clean out the lymph nodes right around the thyroid gland. That's called the central compartment node dissection. And if there are metastatically involved nodes along the jugular vein, we'll do a lymph node removal along that area as well. This is just a picture of a central dissection. We remove all this fatty tissue with lymph nodes around where the thyroid was located and try to preserve the nerves that go to the vocal cords and at least the superior parathyroid glands. If we do that, that will generally maintain normal calcium levels. Unfortunately, once lymph nodes are involved, it's rare. The medullary thyroid cancer is rarely cured, And just to make a final point about complications of thyroid surgery, the two big things that we worry about are recurrent laryngeal nerve injury and hypoparathyroidism. In other words, too low a calcium from damage to the parathyroid glands. So at that point, I'll stop, and if we have time, I'll be happy to answer any questions.
Well, I'm one of your case studies. I had surgery at a local hospital in '87 for hyperparathyroidism, then again in 2000 here, and then again in 2008 for subtotal with an auto transplant. Calcium levels were still running high. They bounced between 10.5 and 11.5. Osteopenia. When they did the last surgery, they felt there was probably something still left behind. What options are available to find? Because I've had the one scan you talked about earlier with the nuclear medicine study and didn't find anything, but my calcium levels never dropped off after the last surgery. What other options are available for exploring something like that?
Sure. And just because a scan does not show anything on day one, it may not, it still may show something 6 months later or a year later or 2 years later. So the first thing that we would do in someone like yourself is reconfirm the diagnosis. Let's make sure the patient does have persistent hyperparathyroidism and that there are indications for recommending further treatment. In your case, young person with osteopenia with early thinning of the bones, that would be a concern, and that would be a situation where if we can intervene safely and not make you permanently hypoparathyroid, then that would be the time to consider further treatment. So in that situation, we would use all of our imaging studies that we have at our beck and call. We can do, we can do more nuclear medicine studies. We can do ultrasound. We now have very sensitive CT scans that can pick up things that we couldn't see before. We can use MRI scans. Sometimes that'll pick up something that none of the others do. We also have available to us here very experienced radiologists who can thread catheters up into the veins of the neck on both sides and into the veins in the upper chest and measure parathyroid hormone levels from multiple sites. And what that might show us is that there's a really high step up in the left side of the neck. And then we can go back and look at our other imaging studies and say, there should be something there. And sometimes, in retrospect, we'll find something once we know where the high gradient is. And if not, we can go in, if the patient, let's say, is having fractures and is having deteriorating renal function, that would be a situation where we would consider going back in based on the venous sampling data that we have, even though we don't have a definite image. Okay?
What's the signs and the side effects of being hypo versus hyper?
Yeah. Well, early on, the patient can experience lots of numbness and tingling around the fingers, toes, around the lips. That can then advance to cramping of the muscles, and the worst scenario would be tetany or kind of lockjaw. Questions? Yes?
You said that 20% of patients have a fifth gland.
Mm-hmm.
Well, I've had 6. Has there been other people that have had more than 5?
You're the only one. No. I'm sorry. Yes, people can certainly have 6 or even 7, but it's very rare. Yes?
How long will subclavian implant parathyroid tissue you can find out the tumor? How long will that last?
Yeah, well, if it takes, it'll last for a long time, and particularly in MEN1 patients, they tend to take very well. And the way I do it with transplanting it just underneath the skin, if it starts to grow, oftentimes you can actually feel it, and it'll light up on a nuclear medicine scan. You can see it with an ultrasound. And if need be, if the patient's symptomatic enough and the calcium's high enough, you just go in and you know exactly where it is. You don't have to go back into this neck again that can be very hostile. You can just cut it out and put a little bit back in and go about your business. And the second one will start to work as well in about 4 to 6 weeks. Yes?
I had the parathyroid surgery. One of the reasons was at the time I had some markers showing that it was testing for pancreatic tumors, and my markers were abnormal. And the doctor said if we take care of your parathyroid issue, these markers may come back to normal. And they did. And so it makes me wonder, I mean, your whole body system potentially is affected by what's going on with the thyroid. Now, I have children, too, and it just makes me wonder at what point does it become an issue for the whole system if the thyroid issue possibly is making things more prone to the pancreas.
Right.
I don't know.
And so probably what you're describing is one of the things that I mentioned. If your gastrin level is elevated, causing you to have ulcer disease or inflammation in the stomach or duodenum, we know that calcium can stimulate gastrin production from gastrin-producing tumors. Not the normal stomach, but from gastrin-producing tumors. And so by bringing the calcium level down, you can bring the gastrin level down, not necessarily to normal, but it can bring it down considerably.
It was not gastric.
Okay.
It was a different.
Yeah.
But anyway.
Yeah. So, and the second part of your question was,
I mean, you mentioned all the reasons why you should have surgery.
surgery, right?
It just makes me wonder if there's something else
Yeah.
to consider that.
Yeah, I think,
Whether it is for a tumor in the pancreas, you don't risk.
right. And that sort of gets to when you should start screening. And as I mentioned in MEN2, you need to start screening very early because these aggressive medullary thyroid cancers can show up early. And in those patients, you want to know what their genotype is, what their genetics are, so that you can intervene and do a prophylactic thyroidectomy at a very young age. In MEN1 patients, it's very unusual for something to show up before the age of 15 or so. And so you can start following those patients. If they have a positive mutation, you can start following them in late teen years. Yes.
Dr. Thompson, there is a new drug that is an orphan drug and may be on the market as soon as November of this year. It's called Para, and that is a synthetic PTH. In one patient that they've had their parathyroids removed and they have troubles with tetany a lot. Do you ever think that that would be appropriate for an MEN patient? Have you heard about it?
Yeah, I have heard about it, and we're interested to see how it's going to work. Always, there's great expectations from new drugs, and they don't always work out. But yeah, if we could have something, because this would be relevant not only to MEN1 patients, but to a much larger group of patients that have had extensive thyroid surgery and end up with limited parathyroid tissue. So this is something that is being looked at. In fact, there is a drug already out there called Forteo, which is a synthetic PTH that's used to treat patients with osteoporosis. And in severe cases of hypoparathyroidism, we can actually give a subcutaneous injection once or twice a day to try to help manage their low calcium level. So it's out there. We're excited, hoping we can find something. It would be ideal if we could have a form that was, say, an intranasal inhaler, as opposed to having to give sub-Q injections like you would with insulin. But this will be a step forward for a critical few patients.
I talked to the president of the company, the pharmaceutical company, and I asked him if he had done any research with MEN individuals with tetany problems.
Mm-hmm.
And he said no, because one of the side effects can be that it can stimulate abnormal cells to grow.
Okay. That I'm not aware of, but maybe that's something that they've found out in the research lab, but I can't think offhand why PTH should do that. Calcium can stimulate hormone production, but I'm not aware of PTH doing it, but there's always new things out there. Thank you.
Other questions for Dr. Thompson?
Yes.
I go to Mayo in Scottsdale, and some of my levels are going up. Is going to Scottsdale okay, or
In the winter, I'd go to Scottsdale. And the rest of the year, I'd come up here. How's that? All right. Other questions?
We've got wonderful endocrine surgeons down there. Dr. Schlinker's been there for Jeff 25 years
Yep.
probably. Very talented, great Other questions?